Dr. Brad Hesse from the National Cancer Institute. He's the chief of NCI's Health Communication and Informatics Research Branch. He's also the director of the Health Information National Trend Survey, HINTS, and the program director for NCI's Center of Excellence in Cancer Communication Research. And he's a nice, extensive CV that I won't try to summarize here, but I will say that a lot of his research focuses on health information technologies and using those to improve the lives of people with cancer. And I also mentioned that before going to NCI, he did some contract research, so he's not just a Fed, he's one of us too. Dr. Hesse, he'll talk more about this, but wrote a very interesting book called Making Data Talk. And after reading that book, it was one that was like, why didn't I write this? I wish I had written this. So that's what prompted me to want him to come. And thanks to Linda Squire's help, we were able to get him to come. So without further ado.
So you guys are really nice folks in so many different ways. Catherine showed me that she had the book well marked, and I didn't bring a copy down. So when you ask questions, I have to look and say, yeah, we did say something about that, didn't we? So I've got that. That's good. But I will mention that one thing NCI did do is that they made sort of a synoptic version of this thing that's available for free. So don't tell Oxford Publishing I'm telling you this, but you can go online at nci.cancer.gov and you can download some of the basic points in, I think it's a PDF. That's probably 100 pages or something. So you might want to think about doing that if you'd like. My background goes back to the mid-1980s. I was doing research on the communication environment at the time, and what we were looking at depiction of guns in the media. So we were studying frustration and aggression and that kind of stuff. This was at the University of Utah. And it turned out that at the medical center at the University of Utah, there was a fellow, his name was Homer Warner, and he was one of the founders of a brand new field called medical informatics. And he said, we need a psychologist to help us figure out what to do with this stuff. And I got signed up. It was the most interesting experience in 1984. I did some studies in the lab to see what people might do if they talked to each other through a computer, because we didn't have a local area network at the time. So I had to learn artificial intelligence to get people to communicate to each other, and they weren't really communicating with each other. They were communicating to a stooge. He was like her, I guess, but without Scarlett Johansson's voice. So it's been just a fascinating trip. From there, I went to Carnegie Mellon. And there was a group that was funded by IBM, and I've been to the IBM campus not too far away from here to talk to them a little bit about this. And we were trying to figure out what would happen if the ARPANET got converted over into what at the time was going to be called the Internet, based on some projections. And we said, I think this is going to change a lot in collaborative science and the way that we think about the world. And in fact, we borrowed some thoughts from a fellow, he was the inventor of the mouse, Doug Engelbart. I don't know if any of you remember him. He just passed away last summer. But one thing he said, he sort of was a Worfian kind of guy, and he said that, languages, that's what Worf talked about, and this isn't Worf from Star Trek, for any of you guys who are thinking in the wrong direction there. Language as an abstraction allows the world to think in more advanced ways. So what happens if we take data and we take that and put it into computers and we make a communication platform based upon data in computers? We can think in more advanced ways. And that struck me at the time. And I thought, that's something I really want to understand. So it's been an exciting time. I went from Carnegie Mellon to Silicon Valley, where I set up a usability lab. I co-founded a usability lab with the American Institutes for Research. So another group you may know of from my dim past, but they had an office out in Silicon Valley. So I got to work with Apple when they introduced what they called a graphical user interface for the very first time. And then Microsoft, about 3 or 4 years later, released Windows 93. They had played with Windows before, I introduced Windows 93, and all of a sudden they invented a graphical user interface, and they invented the notion of usability. Well, actually, Apple had started that before, and the tension was going on and on. But it was a fascinating time to be in the Valley. I was there, by the way, in the 1989 Loma Prieta earthquake. That was the first time that we saw massive groups of people telework and telecommute using these technologies. So we knew the times they were a-changing. Yeah. Oh, yeah, sure. Let me get mic'd up. We have 3 mics working here. I want to be sure I haven't lost anything. And I've got to compliment the team here who has put up with me. We're doing an Adobe Connect webcast, right? Which can only, because it samples at about 5 frames a second, we had to create a PDF. So all the people who might be listening to this who are not here in the room, you're going to miss any kind of video that I'm showing, and I apologize for that. But I didn't want to take the video out of the presentation because part of making data talk is to tell a story through dynamism, and we wanted to keep that in there. So I asked them if they could keep the video in and create this parallel presentation in Adobe Connect. They did that. Wonderful people. Thank you very much for doing that. But anyway, so we're talking about this journey. The other thing that happened to me when I was out in Silicon Valley after the telecommuting stuff, and that was kind of a nice segue to all these people in Adobe Connect, is that we watched as this new thing popped up. And Al Gore, the once and future president of the United States, he was really pushing in Congress to open up the internet beyond science. And he said that we think if we do this, we'll create a national research and education network, and it's going to change education. It was hard to do that at the time because we had Gopher and FTP and all these different kind of technologies. But someone had played around with what was called the Hypertext Markup language project. Tim Berners-Lee had proposed this in CERN. And we ended up working with Mark Andreessen, who was the founder of Netscape, in our lab. And we looked at that and we thought, the web, that may have some legs. and it did. And from that point on, the world has just been going 100,000 miles an hour, talking to people here who are doing work in health communication, doing work in survey methodology, doing work in health information technology. We'll discuss that later in the day, I promise. We just are in a time of dynamic change. And what we wanted to do at the beginning of this last decade, Richard Klausner, who was our director at the time, said, we know a lot about the genomic predispositions to cancer. We know a lot about proteomic biomarkers for cancer, but we don't know how to talk to people about risk. So he launched the Health Communication and Informatics Research branch. And he said, go forth, figure out what to do. And it's in that context that we put together the social science around making data talk, about how to get science and evidence into a patient-provider encounter and into public discourse. Now, I'm a Fed. I got furloughed back in the beginning of October. There wasn't a lot of data going around in public discourse at that time, let me tell you. All the more reason for people who understand evidence, who understand statistics, to be front and center at the plate. And what I wanted to share with you is the world in which the people that we care for, and all of us in this room, but especially at the National Cancer Institute, when we think about the public and patients, what they encounter on a daily basis. So they might get, for example, some message that is tweeted to them about what Suzanne Summers has said more recently on what she thinks is the way to avoid cancer. And, oh, by the way, spoiler alert, she doesn't think it's mammography, colonoscopy, or quit smoking. She thinks it has to do with shark cartilage and that kind of stuff. Or they may hear a little bit from Oprah Winfrey, even, that, oh, I don't know about this medicine stuff, and this really was something that Newsweek brought up. I think that what my parents used to use is good enough for me in preventing heart disease. Or we can get inundated with commercials that say, by God, this Big Mac is all-American. It's all-American beef, for gosh sakes. You should pay attention to this. Now, At the same time, the public does hear a few people coming in and saying, wait, we may be losing this war on health because of our eating habits. There might be a bit of an epidemic. And then not long after that, we see a full-page ad from people who may be getting funds from certain places that are saying, oh, all this is hype. The worst thing is, we're down here in tobacco country. When we started winning the war against lung-bronchus cancer, which we did in 1993, an amazing thing, but we're nowhere near done yet. As we started doing that, the tobacco industry, of course, went internationally. Recognized that there are too many disincentives in the United States. So what if we can move to a new market, such as China or India? And in fact, I've heard some statistics just recently from the presentations at the White House last Friday in commemoration of the Surgeon General's report, that there are more people who smoke in China than live in the United States right now, and it's a big problem. So what is it that this person hears? What are they seeing? And what happened with the internet, which was this wonderful, wonderful idea? Really what people are being inundated with now is sort of a data smog. They'll hear the latest scientists not integrate their finding into what the bigger picture is, what that evidence really means in terms of an action or a behavior. And this was something that we are worried about. We mentioned, Carla mentioned the Health Information National Trend Survey. So we've been tracking since the beginning of the millennium for cancer 3 very specific items related to sort of confusion and fatalism. And the first one has to do with whether they agree or disagree with the notion that it seems like everything causes cancer. So we were hearing that. And we're tracking, here are just 2 administrations of the survey. We've had about 4 or 5 now. And if you see from 2003 to 2007, I feel like I'm holding a Bible here, so I'm going to put this down for just a minute. Can I get an amen? If we looked at strongly agree and somewhat agree, I want you to see how together we have an overall 7.7% rise in people who are buying the notion there's just too much going on to understand what really is causing cancer. That's our science actually speaking to these people and getting lost in the media somehow. We look at another question, which is sort of an efficacy question, is the way we term it in social science, behavioral science. So do people think that they can actually do something to reduce their risk of cancer? That's important for us because about 50% of cancers can be prevented through behavioral kinds of modifications and close screening. And in fact, we do see a decrease in confusion that. We see that people understand that there are things that they can do. That part's good news, but here's the third part of the trifecta. They think everything causes cancer these days. They think there's something they probably can do to prevent it, but if we ask them, are there too many recommendations on how to prevent it, it's hard to know which ones to follow. That's actually increasing. So people think they can do something about it, but they don't know what it is. There are too many recommendations. It's a cacophony out there of signals. Here's another example of how that can happen in the media. I'm borrowing a report that was done on BBC broadcasts. So this came out of the UK at the beginning of the last millennium. And I want to show you just a content analysis of the type of stories that were being written in the BBC News and broadcast in the BBC News. And if you look what accounted for the majority of stories, it had to do with healthcare. They have National Health Service over there. And I think if you were to go over the past 6 months, if you were to look up healthcare exchange or Obamacare or something, that would probably dominate in a similar way. But when it came to actual health risks, the number of stories were dismally small. So people weren't reading about what's going to kill them and what they can do, more importantly, to avoid that. They were reading about the latest scandal du jour in the UK. Calculated how many deaths it would take to merit a story in the BBC. Turns out it would take for smoking something like 8,571 people to die before you get a story in the BBC. But when it came to measles the rare stuff, AIDS, then it wouldn't take much at all, actually, to get something on the news. This was done at a time when mad cow disease was big, which is why you see some of the BCID books. All right. This is something that's disturbing. Let's take it into the United States. A good colleague of many of us here, Ed Maybach, who's now over at George Mason, looking at the delightful world of environmental communication, released a content analysis a number of years ago that's kind of similar in structure, but here in the United States, and taking a look at the kinds of stories that really would dominate the media compared to who's actually dying from these various causes. And you'll see tobacco, most people are dying from that, but there's just a small number of stories that are produced related to that. You look at something like toxic agents, though, you get a lot of stories on that. Brockovich cells. But people don't really die from that as much. So here's a conundrum we, as people who deal with data, are facing. We want people to know what the real story is. Now, there's good news. And the good news is that for a number of years now, and NCI has been investing in this, people have been studying the science of communicating data. And we have a feel for what to do, and that's what the book was about. It was bringing together across 7 different disciplines and literatures, because it's not all in one place, what we thought was the best set of recommendations based on evidence for how to communicate data. Here's how Matt Nisbet talked about it at American University.
We're starting to see a paradigm shift in how science institutions and scientists think about the communication process, going up beyond the natural audience for science and thinking about really taking a scientific approach to the communication of science. Drawing on a lot of the social science research that's grown up over the last 20 years in the sociology of science, in science communication, and also the application of political communication to this area.
So I was going to look up the cartoon here. There's a wonderful cartoon that of these two sort of old scientist codgers talking to each other, and says, "One thing I'll say for us, Meyer," and they're surrounded by their papers. We never stooped to popularizing science. This was kind of the notion back in the 60s and 70s, actually, is that, and the 50s, I mean, it began with Vannevar Bush to a certain degree, that science was something that's practiced behind the hollowed halls of the ivory tower. You wouldn't, we wouldn't stoop, you wouldn't reduce yourself to actually talking to real people about this. That changed. The day that changed, I think, was 1993, when Tim Berners-Lee created HTML. And then Al Gore said, let's push this and see if we can open this up to the world. The first thing that happened, and I did some of the research with the Centers for Disease Control and Prevention. I think Linda might have actually helped with some of that. Where we looked at who was hitting the CDC's website. They thought for sure it was going to be other public health people. But when we looked at who was actually hitting it, 66% of the traffic was coming from the public. The web disintermediated our door to data and health communication. That's why people are getting confused, because we weren't ready for it at the time. People were knocking down our doors, and they wanted the data. And they were going to get the data come hell or high water. Another memory I have, my wife is an OBGYN. And the day that the Women's Health Initiative announced that it was stopping the Prempro arm on estrogen, remember that? Progesterone. All of a sudden, her phone went off the hook. It was on my birthday. I remember that. So it's July 9th. And her phone was off the hook because people were saying, now what the hell do I do? What had happened is that the news hit NPR with the pre-release edition of the story on Tuesday. It was posted through NPR and other sites by Wednesday. It went viral by Thursday. That's when she started getting the telephone calls. Her JAMA, in which the story was written, arrived by post on Saturday. So this is the communication environment. People want data, they're getting data, and it's up to us to give them that data in a way that makes sense. And I think there are ways to do that. It depends on how you're going to use the data, and that's a lot of what the book is talking about. But I also remember in the early 1990s, there were conversations about using satellite telemetry while you're driving to get you from one place to another on a map. And I thought that was the craziest damn thing I'd ever heard in my life. and I can't go anywhere without my GPS. So I'm pretty sure we can find ways of making data talk. But I want to get to this notion of sort of 4 functions that we'll discuss a little bit that we put into the book on how we use data. So many people think of the persuasive side of data. Boy, I'll use big numbers, and that certainly will grab people's attention, and there is a place for that. But there's also an important side to simply educating the public and getting us all on the same page and using data and statistical trends so that we speak the same language. And this is very important. There's a fellow psychologist by the name of Dick Nisbet who said that the worst enemy we have, and we'll talk about this a little bit later on, is anecdotal thinking. And you hear this on the news every time. Well, I talked to so-and-so, and they said they didn't get a mammogram, and they live forever, you know, that kind of thing. It was big back in the 1970s when I knew someone who was a friend of a cousin who got thrown from the car because they weren't wearing their seatbelt, and they lived, right? But the minute you counter that with what he calls statistical thinking, to help them think what the actual trend is, what is the likelihood that you, by the way, will get thrown from that car and live versus die if you're not wearing a seatbelt, that changed minds dramatically. We can do a lot from data. Imagine if my GPS were making stuff up, MSU. You know, I don't think I'd go very far. I'd probably die. I need real, reliable data. So, and we sometimes in this country, some of the narrative and dialogue is veering away from science and data. So I would encourage us here who have an obligation to bring that data to life to think about how to make that happen. So we put into several chapters, we tore apart the various pieces of communicating data, but we had one chapter, chapter 5 in particular, where we brought it all together, and we used an opt-in framework, is what we called it. Opt-in because we wanted our scientists and our data statisticians to really get into the conversation. We think not communicating is communicating. And I know this from bitter experience at the NCI, because when we had a change from the U.S. Preventive Services Task Force on mammography recommendations, the first thing that NCI did was duck and cover. And they shouldn't have. That was the worst thing you could do. We try to get NCI to think beyond that and be a little bit more proactive and get out in front of the story. But they didn't do that. They're changing over time. But this is what we have to think about. So, but opt-in, we put it as organizing, planning, testing, and integrating. Now, I'm going to talk to you a little bit about each of those for a minute. So in terms of organizing, what we think is important up front, whenever you get if it's a request for a telephone call with a newspaper reporter, or it's a chance to do a briefing at City Hall, or it's just simply making a presentation to a client, think about exactly what is the evidentiary story, because you're going to be the one to get beyond anecdote, beyond narrative, and orient people to what the data are telling you. And then also think about what the functions are that the data will serve. Are you going to use it to persuade, or are you going to use it to support decisions? Or are you going to use it to educate, or are you going to use it to inform? And also really understand how these data fit into the bigger realm of science. Is it a settled science, or is it an unsettled science? Is there ambiguity about it? Or, as most scientists, we tend to shoot ourselves in the foot and say, oh yes, you can only falsify hypothesis. Thank you, Karl Popper. So we can never really know if there is truth. There's always doubt. And we'll see how that got used against us by the tobacco companies in the 1960s and 70s. We can't afford to do that. If we do have confidence that the science is settled, we need to bring that with data to the public. But here's an example. I know that NIEHS is not too far away, I think, down here. And we work with the breast cancer group there because they struggle all the time with how to present information they're collecting about the risk of the environment on something like cancer. Now remember, the Aaron Brockovich meme is gigantic. Toxins was the biggest newspaper story. It's easy even to dupe ourselves when we look at this unsettled data and say, dang it, you know, the chemical companies down the way are contributing to a cancer cluster. But we can't afford to do that. We have to think objectively. We have to recognize that a lot of what we're going to do at this stage, if we don't have settled science, is to inform and support decision-making around unsettled science, around uncertainty. And that's what we have to do. We're going to have to do that more and more in medicine between physicians and patients. Sometimes the path forward in a prognosis is not clear, and we need to be very open to what the decisional paths are around that. On the other hand, I would argue that something like tobacco and cancer, okay, we got that one nailed. We got that figured out a long time ago. And in this case, it's a matter of educating and perhaps persuading audiences and using data in that function on this settled science. And there was a lot that just happened, I mentioned last Friday at the White House in celebration, commemoration of the 50 years since the Surgeon General's report. And if you get a chance to look at that video, it's worth looking at. Anyone who cares kind of about the influence of tobacco on American culture and health. Because the new Surgeon General, acting Surgeon General, is not pulling punches. Howard Koh is not pulling punches. The Secretary Sebelius is not pulling punches. The President's not pulling punches. And they load their story with data. 1 in 13 children, as they said last Friday, will see their lives shortened in this nation because of the influence of combustible tobacco. Still. And they would put in that kind of data through there. Now, we can even take something like this, which is around education and persuading, and we can say, you know what, a lot can happen in the world of the internet at the community level. I wonder if there's a way to present nationally knowledge, attitudes, and behaviors so the communities can take action on them. And we did experiment with that using data from 2 of our data sources in a notion of health information surveillance. One was the Health Information National Trend Survey, and the other one was the SEER Registry for Surveillance and Epidemiology and Results. That's our registry data we have on lung and bronchus cancer and other kinds of cancer. But what I want you to notice is that we took a national survey, which is 7,500 people, I said, around the nation. And people came to us and said, okay, well, that's nice you got that survey. How about me? I live in Kentucky. How about me? I live in Utah. How about me? I live in California. I live in Florida. And we didn't have the statistical power to give people the information they needed so they can make some decision-making based on these data. But we, as we looked and kind of got in the course of the book, to the various ways of visualizing data, we recognized that we used a very specific headbanging algorithm to borrow information from different parts of the nation, like neighboring areas, so that we could create an isoplex map. It looks like a weather map. So here's another example of people who get exposed to data all the time. People look at weather maps all the time. And they don't look at it and say, oh, there's a big storm that's in Virginia right now, but we don't have it in Maryland. I think I'll just go outside in T-shirts. No, people recognize that, well, maybe there's a regional occurrence, and we should pay attention to that. What I want you to look at on this isoplex map, this is from the 2003 data, we were getting concurrence with the notion that smoking leads to cancer. That little spot along Appalachia, that light green, these are people who don't buy it. Now, that's a relative term. Most people have gotten the message, but overall, relative to other parts of the country, these are people who didn't get it. If we juxtapose that against where people are really dying today from lung and bronchus cancer, it's startling how close that is. So we thought this could be a method for informing communities that we need work done in this region to really get some basic health communication back on the map, if you will. So that's an example of how we can move that over and even inform in the area of tobacco. Let's move over to planning, the next notion. And planning is a matter of looking at people. And today, as we have a push-pull environment, I like to think of people more as sort of users of information, as participants of information rather than audiences. But I'm going to use the term audience here because that's what we wrote when we started putting this together in 2003, 2005. Sort of a term to art. But you'll get what I mean. It's really people using this information. We're going to talk a little bit about messages, and we're going to talk a little bit about channels and timing, and we'll find some interesting things, I think. So first off, let's look at audiences and figure out where they struggle and figure out how to meet them in terms of our messages so we help them overcome their struggle. I mentioned earlier the Dick Nisbett notion that anecdotes can carry a lot of weight in the news. And so some of you know about this whole meme that's been going around on vaccines we care about it with HPV vaccine and autism, and there are certain political candidates from a few years ago that actually bought into this, as a matter of fact. So it's dangerous exactly how frightening that is. But for a lot of research that's been done, most of it suggests that if you can get away from people's fallacy of small numbers and present information in a way that shows exactly, this is the seatbelt usage, how probable it is out at the extreme versus what really the data are telling us, that we can eventually turn the whole thing around. That happened in the 1970s. We're starting to do it now with even some of this misinformation and anecdote. Come back with a story based on data, and it can help turn that around. Now, do it skillfully. Do it paying attention to your audience. We can also look at basic human factors, where human factors is creating an information environment that is compatible with the way that we see, think, and feel. That's what human factors is about. So whenever I talk about human factors to a group of people, they say, oh, it's changing people. Oh, no. It's changing technology. It's changing people. It's getting that GPS to talk to me in a way that can actually get me from point A to point B without crashing. And that takes a lot of work. When it comes to data visualization, there are a lot of perceptual rules that artists and designers kind of get. And we've got a lot of data on them. So the power of something like proximity, things that are close to each other are related to each other. The power of similarity, of continuity, we can use that, I'll show you in a few minutes. The power of closure, the power of area and symmetry. We can take all of this and we can start applying it to the way that we create visualizations. We've tested a lot of these out in our lab. One of the sources of information that I found very fascinating was from education. And they did eye tracking studies. They studied people as they looked at educational charts and textbooks. And they found that what people did is that they focused on the center of a graph first to figure out what the pattern was. Is it going up? Is it going down? And then they put a label on it. They said, oh, and that's what is going up, and that is what's going down. Now that's counterintuitive to a lot of people because legends get built way off to the side. And they don't often get put in the middle contiguous with the actual pattern, but that's where eyes are going. So we'll show in just a second how there might be a way of changing that. So here's an example where we put cues in the center of a graph using continuity to show over time what changes look like. That's the reason why that line graph works so well. And then we're able to get a little bit better understanding with people by doing that. Here's another example. If you were to go in and do a survey of obstetricians and gynecologists and say someone came in with a positive mammogram, what is the probability that they have breast cancer? That study's been done. Geiger has done that quite a bit over in Germany. And the answer they give is usually around 85, 89%. It's really around 8%. So Bayesian statistics are really damn hard to understand because it's a contortion, actually, of the way we think about the world. But someone like Dirk Eichenrenzer, this psychologist who has been looking at ways of undoing that, said that, you know what I can do? I can use natural frequencies. People understand the way things occur in the world. So I can show how many people, let's say, are taking hormone therapy, and then show them what happens when we add additional therapy in the terms of a decision, and how big that difference might be. So you see these two little yellow dots over there. This is called an iconograph. And specifically, there's a woman that we funded up at University of Michigan, Angie Fagerling, who's done a lot of work on these iconographs. And by presenting these kind of Bayesian statistics for decision-making on treatment, this is adjuvant therapy in this case, or on even something like screening, we can get comprehension all the way down to about the 12th grade. Well, actually below that, I think about the 8th grade. So we can get adolescents to understand Bayesian statistics without calculating anything. The trouble is, I mentioned the fallacy with obstetricians, gynecologists. These are very smart people. I married one, so they've got to be smart. But they're under a lot of pressure. They're not going to go calculate Bayesian stats immediately, so they need decision aids, and they need decision aids that are compatible with the way we think about numbers. So that's kind of the notion. What I'm especially concerned about now is that we're rolling out electronic health records. So this is something we've been pushing on for a long time. We believe it's important for you to have every component of your previous history presented, let's say, to a primary care physician who's going to see you as a cancer patient or see you as a cancer survivor. They need to know what drugs you've been on before. We want that to happen. We can do it in finance. We need to do it in medicine. And it's happening. We're up to about 80% penetration among practitioners now. But repeatedly we hear these systems are unusable. They're old accounting systems. We need people to apply that same kind of thinking. This is work that was done by Ben Schneiderman. He's a usability person up at University of Maryland, to find ways of showing temporal sequences immediately in the clinical encounter. And we know that it can be done. So this is an area to keep moving forward. So the piece to recognize kind of on the psychological side, the cognitive side, is that all of this perception is a constructive process. Gaze typically goes to the center, and that's where it moves out from. Contiguous labels help with meaning. There is a left-to-right tendency in Western culture, opposite in other cultures, and that we can use these perceptual rules in our lab. And you can even do that to present information very dynamically that would have otherwise been the purview of social demography and health demography. And many of you recognize Hans Rosling, I think, who did the Mind the Gap. He's one of the first folks that inspired us to say, you know what, it's amazing the kind of stories you can tell about the world as it is based on evidence instead of anecdote, and that's what we can do. All right, so we talked about, another part of planning is this whole notion of messaging. There's a lot in health communication science about messaging. Something that Matt Nisbet talks about is that there are some basic frames that get repeated a lot on frames of social progress, economic development, morality, ethics. And what can happen is that those frames can get used against us sometimes. Let's see if you recognize this frame.
Have they been proved to be safe, Mr. Coleman?
I believe they have not been proved to be unsafe, because when, as and if, any ingredient in cigarette smoke is identified as being injurious to human health, we are confident that we can eliminate that ingredient. And I concluded from that it was true that babies born from women who smoke are smaller, but they're just as healthy as the babies born from women who do not smoke.
What about the higher rate?
And some women would prefer having smaller babies.
1971. I think Philip Morris, CEO, may have had an ulterior motive to believe the way that he believed. But not only that, we know through discovery that there was a significant marketing attempt to downgrade the knowledge that we had, to say, in fact, that science is always in doubt. And you'll hear this story every single day in the media. Well, scientists say this about global warming, but not all scientists agree. Okay, 99.9% agree. But I knew a guy in Scotland who didn't agree once. You know, be aware of that. And it's okay to be certain when data are telling you a pattern. You can still recognize that there's some probability associated with that, but the pattern is telling you something. And you don't have to do anything in boring kinds of ways. So we can do what the American Legacy Foundation did, in which RTI helped evaluate at one time, and that was the Truth Campaign. It said, we know that kids kind of naturally are suspicious of authority. Let's take that to our advantage, because maybe these guys, like this 1971 CEO, may be giving them a spoonful of BS. And let's see if we can show that.
Here for you, so you can see what 1,200 people actually look like.
One reason why I like this is that it's based on data, 1,200 people. But there's no numbers. It's a visceral showing of effect and quantity. Very persuasive, I think. And then channels. Obviously, over the past 10 years, we've been watching channels, a mix-up in channels. And we're paying attention to that, certainly. I would remind us that as we think of multiple channels, and not just simply the Snapchat du jour, but we think instead of how people still want to interact with their physicians, And there might be communication lines that we can use to take advantage of that through new health information technology. That would have an implication for how we get out to these different channels. And we also should allow ourselves to be surprised a bit by the data that all of you are collecting and that we're collecting also in the Health Information National Trend Survey. So when we were looking in 2008 and 2009, one of the first surveys to pick this up along with Susanna Fox at Pew, that as we started really getting into the subgroups that were getting into social media, we found a bigger effect among Black African American and Hispanic groups than among non-Hispanic whites. And so we think in this new world, use your data to find out where the channels are and then create plans to get to people at the time they need it with the message that they need. Patty Brannon, who's up at University of Wisconsin, likes to talk about this as providing information at the point of need rather than the point of care. We've had an old mass media approach to medicine in the past, and we need to get away from that. We need to be able to figure out what people need when they need it and give them that information. So that's part of what we're working in terms of data from the electronic health record. Testing and integrating. Testing is your middle lane. That's a lot of what you do. So a lot of the user-centered design that Greg, you've done, and others have done around here, Linda and others, very important. Keep up the good work on that. Usability testing, focus groups, informal feedback. We're not very good at that at NCI, though we did have the first usability.gov years ago. And then more importantly, we think we're pushing into a world of translational research. We think that applies to electronic health records and to the very communication we have about health and disease in the translational space. So there's going to be a big need. The CORI, the Patient-Centered Outcome Research Institute, is putting a lot of money into understanding what this comparative effectiveness might look like in this new platform. So is the Agency for Health Research and Quality, and NCI is investing also into translational research. So you should see new opportunities available in this area as we move forward. So testing is going to be pretty key. It took 10 years, by the way, to get that GPS to a point where people could listen to it and not crash their car. And then finally, and this is a big piece that we've been pushing, is the notion of integration. So we had stovepipe communication for so long that when one of the biggest problems we get from our users and people in the survey is that they don't know what the big picture is. And journalists add to this problem by talking to a young scientist who found a little finding, and it says, I think that rutabaga contributes to eye cancer, you know. And then all of a sudden that becomes the big news, and it's a small little finding, not integrated into the bigger picture, what the U.S. Preventive Services Task Force could do for us. But it gets blown up on the news, right? As an anecdote, as a little N of one, even though it was a scientific study. One way that we see the millennial generation taking advantage of this is that as the newspapers reinvent themselves, a lot of folks will go to websites that are now operated by local news groups to find out what's happening in their own backyard. That's powerful. The New York Times took the lead on this years ago. And if you go to their website, if you want to see how the economy was doing over the past, how many of us did that, watching our stocks go since 2009, how many of us visited the New York Times website? Beautiful graphic visualizations to inform the public, as they had to do risk management in finances. Well, let's apply that same behavioral economics to medicine. And this is one example. This is someone out of Berkeley that's doing this one, but he's done this around the country. We opened up our health data nationally, and then he was able to use those data to present community progress on something like breast cancer, mammography, colorectal cancer screening, things that communities care about. It's community-based participatory research, if you will, hooked up with quantitative data, and I think that's going to be a big, powerful area in the future. Here's an example of some work done by a grantee in Missouri to turn them around. They're one of the worst when it comes to lung cancer mortality.
Missouri, the show me state. Missouri was the 24th state welcomed into the Union. It ranks among the top 10 states for business and boasts some of the best financial, educational, and medical institutions in the country. But there's one place where Missouri's high ranking is nothing to boast of, and that's smoking. Missouri's smoking rates for adults and kids are among the highest in the country. The dangers of smoking have been well known for a long time. But believe it or not, smoking is still the #1 cause of preventable deaths in the United States. Let's look at smoking rates across the country. Utah and California have the lowest rates, with just over 10% of adults smoking. Missouri is a different story. It has the 6th highest smoking rate in the country at nearly 25%. That means 1 out of every 4 adults in Missouri smokes. Kids in Missouri smoke at high rates too. Almost 19% of Missouri high school students smoke cigarettes. That's about 1 out of every 5 students. And things are getting worse, not better. Turn back the clock to 1985. Missouri's smoking rate of 28% was in the middle of the pack among the 50 states, about the same as Hawaii, Iowa, Massachusetts, New Jersey, and lower than many states like Rhode Island. Where are we today? In the 25 years since then, smoking rates in those states have steadily dropped. In Rhode Island, smoking rates fell from 34% of adults to just 15%. Missouri was left in the dust. In the last 25 years, Missouri had the smallest decline in smoking rates of all 50 states. Dead last.
Interesting choice of terms. I apologize for those that are on the Adobe Connect that they couldn't see that, but I wanted you to see how that introduced dynamism to the story. And I think was very compelling. They're presenting it now to state legislators and also to the state. You'll notice a social psychological process in that called social comparison. If you want to really kick someone, you say, this is how you're doing compared to the guy next to you. And they did a pretty good job at that. But it is missing one piece that we look at in health communication. So in health communication, if you do a bit of a fear appeal, like danger, Will Robinson, something's happening, that's good, but you got to tell people what to do next. So this is how they did that.
Cigarette prices, clean indoor air laws, and prevention spending. What would happen if Missouri changed these things? Take the state cigarette tax. If Missouri increased its tax by $1 per pack, it would still be lower than the national average, and cigarettes would still be cheaper than in 22 other states. But that extra $1 per pack would mean over 39,000 current smokers in Missouri would quit. Another 60,000 children would be saved from becoming addicted smokers. It would also raise close to $323 million. And it would save the state $1.4 billion in health costs long term. What if Missouri had a statewide clean indoor air law? The impact would be immediate and would benefit smokers and non-smokers. Studies show that within weeks of taking effect, clean indoor air laws reduce heart attacks. Lung cancer rates also drop as more smokers try to quit. And what would happen if Missouri invested more in preventing smoking and helping smokers quit? Nicotine gum and patches that help smokers quit could be made available. Businesses that break the law and sell cigarettes to kids could be caught and punished. Other states have done this, but Missouri hasn't. That could change. How much would these steps reduce smoking in Missouri? Going back to 1985, 28% of Missouri adults smoked, the same rate as Hawaii, Iowa, Massachusetts, and New Jersey. In the 25 years since then, Missouri has done little. It raised the cigarette tax once, but only by 4 cents per pack. It has not passed a statewide clean indoor air law and spends just 21 cents per person on smoking prevention. The result? Little change in smoking rates for a quarter century. During the same time period, Iowa raised cigarette taxes by $1.18 per pack. It enacted a statewide clean indoor air law and spends $2.58 per person on smoking prevention. As a result, its smoking rate has dropped by 42%. Massachusetts increased its cigarette tax by $2.25 per pack, adopted a statewide no smoking policy, and spends $1.59 per person on smoking prevention. Its smoking rate has dropped by 46%. It's the same story in nearly every state. They've done what Missouri hasn't and cut their smoking rates by 30% or more. And the gap between Missouri and these other states isn't just numbers on a chart, it's real people. Hundreds of thousands of people in Missouri who are smoking and dying from smoke.
I'm going to move on because I feel like we're beating up on poor Missouri. But you get the point. I mean, a way to talk to policymakers, a way to talk to the body politic around data that's very persuasive, and it's also very informative. It's hard to get around that. So that's some of what we're thinking about doing. What I want to finish up on is to talk a little bit more about how the world is changing, even beyond the old ways that we would communicate data. One way that it's changing is that we're introducing data into health systems. And we're pushing from the Institute of Medicine down on getting a learning healthcare system that uses data on practice to improve better practice, to help accelerate discovery. We're entering into a world of big data, which means that the old assumptions we had under hypothesis-driven research, really the third paradigm of science, are giving way to the high-end statistics that can happen with data mining and big data. And you'll see some wonderful opportunities coming out of the NIH on that recently. We're entering into a world where people are going to start using data on a daily basis. I mentioned GPS, but people also benefit when they go to Amazon.com and something gets recommended to them that's being driven off of user data. And I would assume that you're going to hit data all the time in ways that you don't even know. This is what Tim O'Reilly said when he first talked about Web 2.0. He said it's about a platform for change, it's about participation, but more importantly, it's about data being the common language, the new intel inside. So data is going to be very powerful. I did a presentation on this, and we were doing some early experiments in 2005, 2006. We were juxtaposing some data onto a map. And we said, you know, maybe we could take a different approach at NCI, and instead of always being the weatherman, we could be very similar to the way that the National Oceanographic and Atmospheric Agency operates. We can start presenting data to the smart weathermen and application developers who will then take it the last mile to the public. Get government out of that business. For this presentation in London, Greg Gowning at the Department of Health and Human Services heard that and went to Todd Park, who is now at the White House. He's now the Chief Technology Officer at the White House. And that opened up, that began a series of efforts to open up data like we've never seen before. And some of the idea behind that is as we start creating a participative environment in health, that we can take advantage of other data structures, such as the data structures that Google have put together for us on maps, where we can place into local areas where there might be health hazards. We can get citizen scientists to go to areas because we hear there's bad air quality, let's say. Measure that, report that back. We're working with the National Science Foundation to do that. We're also working to figure out if we can condense data into a weather map. Why can't we take the same approach to create something that could inform patients and providers? And in fact, there's some work being done in that area. So we're very much part of what the Office of the National Coordinator for Health Information Technology is doing and thinking about what it means to get data flowing through our health system. And then let someone with cholesterol, like me, high cholesterol, check my Kaiser record on a monthly basis, a quarterly basis, to see if I've made a difference and change. It's very empowering behaviorally. So it's a way we're making data relevant to individuals. And in doing so, we're going to start embedding data, I think, into health and medicine in ways that we've never done before. And so look for that, look for opportunities to help contribute to that. You may have seen from the Department of Health and Human Services a notion of Datapalooza, the Community Health Data Initiative. That's been going on for several years. That will continue going on. It's an effort to combine the various data sources across agencies, finally get intergovernment cooperation. We struggle with that on the healthcare rollout, but we can do it in other areas. This is back to that Health Matters in San Francisco I showed you earlier on. But the really interesting thing is, as we start thinking about a global internet, the World Wide Web, other partners now are playing on this scene and depending on the data that we create. And in fact, that, I think, is what we can start expanding our vision to consider next. Because what can we do to make these data work not just at a community level, not just at a national level, but how can we get community participation around the world. And I know that RTI is investing in global efforts, but to do it around data would make a lot of sense. This is the way that Tom Friedman talked about it several years ago when he wrote the book, The World is Flat. Listen to this, my last slide.
That's what I mean when I say the world is flat. I mean we have created a global web-enabled platform for multiple forms of sharing knowledge and work, irrespective of time, distance, geography, and increasingly even language.
Making data talk, we think, is big. And thank you for doing all that you're doing down here to make this for the difference in people's lives. Thanks. Are there any questions? I don't know how much time we have. We only have 5 minutes. Is that right? Or longer? Catherine knows the page number if anyone needs. Thanks.
That was a wonderful talk. You should do a TED Talk based on that. It was wonderful. I'm wondering if you could comment briefly on something that bedevils those of us who really try to emphasize readability, and that's the movement towards plain language. I was very much taken with the graphical kinds of examples you gave, but I get the sense that the federal government and others are increasingly trying to push formally plain language, and I'm curious to know how that fits in with all that you're doing.
Yeah, you know, when we in the book when we talked about being able to communicate health information and talk about health, we said that we do that through words, numbers, and symbols. And words is where we begin, right? That's the notion of plain language. There was this sort of 1950s, 1960s Mad Men notion of the scientist again in the ivory tower, pay us big money because we speak a language you don't understand. And then it became very difficult for anyone else to participate. When we tore down the walls with the internet, people all of a sudden started grabbing those initial JAMA articles and making sense of it. That means we have to do something to deal with that. We're underserving Hispanics on websites. There's a new report that revealed that a couple of weeks ago again. We knew that back in the early 2000s. And we have to figure out better solutions to making our information usable by the most amount of people. We talk about universal design, and plain language is around universal design. And the idea about universal design is that I can create the same GPS for my car that I can create for a professional pilot, or I can create for someone in a boat. And that also kind of flies against the magic of Bayesian statistics. But if we could make a plain language for a patient, and then a doc can look at that and say, oh, well, you know, here's the probability of actually having a tumor, a malignant tumor, based on that that positive from your mammogram. It helps them as well as helping others. So we talk a lot about how cognitive overload is some of the problem that we struggle with in this new age. And plain language, which strips out all the technical jargon to get the message across, is going to be the common platform, we think, to inform both professionals as well as patients and the public. So we're believing in that, and we try and push it from NIH wherever we can in a Sisyphean effort. We want to eschew obfuscation.
I think challenges in communicating findings is whether it's news in print media or on the web, what sensational sells magazines, gets hits, and we tend to take more of a nuanced, very, load up the caveats. But I think, for example, about the whole crack babies issue. And so how do you overcome a popular perception with data when something has gotten very sensationalized?
Yeah. So some of the so the question, I'm reminded that people need to understand what the question is from the audience who are on the webcast, how do we swim like salmon upstream against the popular media and against a Twitter stream and a Facebook stream that seems to grab just a snippet of sensationalism and makes it the message before we can get hold of it. And it's not a simple answer, unfortunately. But I'll give you a couple of places where we can lean forward on that. One thing that we found, this is work done by a fellow named Joe Capella up at the University of Pennsylvania, the Annenberg School of Communication, is that he was noticing when the newspapers talked about genetics, there was a new genetic finding, they took a very deterministic view in their write-up, in the headlines. So he did an experiment. He said, well, what if we alter the way that we do a press release? And instead of just doing a press release kind of sculpted the way we thought would be good for them, we included a hand-to-hand conversation with the original scientists. That beat the pants off the first one in every case. And what was happening is that once the journalists felt that they were in a team with the original scientists, then the journalists could say, look, I got to get takes my editor, I got to sell papers, what's the story? How about if I go with this? The scientists can correct and say, no, that's not really what the evidence is telling us. So I think this notion of joint participation is big, and that may help us out. One of the ways that Wall Street Journal manages to keep our conversation about finances grounded is their use of graphics to say, here are the data. So that's another way that we can make that happen. And then third, the horse is still going to leave the barn all the time. And when that happens, recognize that and get back up, correct the misperception immediately, do it with data and from a credible source, and it usually squelches it before it goes too far out. The paralysis we have of, oh shoot, this thing is happening, they're talking about mammography in a dangerous way, and then backing off is what creates some of the problems. So, hop in. All right, I guess we made data talking now. Good. Thanks all.